Hello everyone, my name is Erin Niehaus. Welcome to my doctorate in nursing practice presentation, Improving End-of-Life Care in an Inpatient Oncology Unit, a Quality Improvement Project. Here are my committee members, my DMP chair, Dr. Teresa Galactos, second reader, Dr. Lisa Stewart, and my practice member, Kelly Hearn. On this slide, I will be discussing my personal biography. I graduated from the College of St. Benedict's with my bachelor's in science in nursing. I am currently enrolled in the BSN to Doctor in Nursing Practice program with a focus on family practice nurse practitioner at Maryville University. My planned graduation is December 2021. I work as a clinical resource nurse in a Midwest hospital on an oncology department. To begin my presentation, I will start with my presentation on phenomenon of interest and the importance of this project. As many of you already know, the United States population is continually aging at an alarming rate. It is predicted that individuals over the age of 65 will increase by 73% between 2010 and 2030. Furthermore, 33,000 geriatricians will be needed in 2030 when there are currently only 8,800 certified geriatric practitioners. This is an important statistic for anyone in the healthcare field and general population due to the extreme shortage that will become apparent in the coming years. With that being said, baby boomers are living a longer life expectancy with more comorbidities present, making management much more costly and time-consuming. This segues the conversation in towards end-of-life care and the increasing burden that will be placed on the healthcare facilities. According to Beckstrand and colleagues, nearly 1/3 of the population dies in the acute care setting. Knowing this, there is a huge importance on providing adequate end-of-life care to these patients. The healthcare staff is expected to be attentive and mindful to patients and families throughout their end-of-life and grieving process. Unfortunately, last satire determined that over 2 million hospitalized patients have unmet end-of-life care needs. There are multiple contributing factors to this, which include lack of adequate palliative and hospice team members and lack of adequate education, experiences, and resources, leading to a huge financial, emotional, and physical burden placed upon nurses and the healthcare team. Better understanding of end-of-life care and actions and activities that are facilitated by nurses can better prepare the healthcare team for the upcoming burden placed on the healthcare system overall. Moving on, the question this project poses: what anticipatory bereavement activities and resources were utilized in one oncology unit over 3 months? It is important to highlight the vast array of literature regarding the subject of end-of-life. 4 themes became apparent as I sifted through the research. The first theme was grief, loss, and bereavement. Grief varies depending on social, cultural, and religious beliefs. A normal grieving period lasts between 6 to 12 months. When this does not occur, individuals experience complicated grief. This is a prolonged period of sadness that is associated with higher rates of depression, suicidality, social isolation, and post-traumatic stress disorder. There are many predisposing factors that contribute to an individual experiencing complicated grief. These include the inability to say goodbye to a loved one, dying in an intensive care unit, and an unprecedented death. A particular study I found fascinating, conducted by Gessie and colleagues, found that 52.1% of individuals out of a 282-person study experienced complicated grief after a loved one passed away in the ICU. Furthermore, 2 to 7% of the general population suffer from complicated grief for various reasons. These increasing numbers may be due to inadequate access to physicians, lack of communications, unanswered questions, and lack of adequate end-of-life care. Another factor that contributes to grief, loss, and bereavement is the use or no use of a palliative or hospice care team. This team facilitates symptom management, quality end-of-life care, and encourages goals of care discussion. Early implementation of a palliative care was found to better prepare 217 family members and patients for death and ease the post-bereavement period over a period of 18 months. Nurses play an important role in the grieving process. When an individual passes away in the ICU setting, there's an increased physiological and psychological problem that develops for family members. Nurses can assist in the grieving process by implementing bereavement screenings, support programs, and follow-up meetings. This brings us to our next theme, end-of-life interventions. Nurses can utilize various end-of-life interventions to help facilitate the end-of-life process. Various protocols and guidelines have been developed for nurses to utilize throughout the end-of-life process. A particular protocol developed by Rogers incorporated bathing and prayer after the patient passed. This helped build a positive experience, supported grief, evoked and supported emotion, facilitated transition, helped understand the reality of the loved one's death, gave direction, and was meaningful. Another protocol that utilized memory keepsakes boxes in an ICU setting that included telemetry strips, valuable low-cost items, and pictures provided the family with valuable items that facilitated the beginning of the grieving process. Education plays an important role in adequate end-of-life care, whether it be through in-person or online modules that focus on end-of-life can help assist the nurse in being comfortable and prepared to provide the best end-of-life care. The next theme is non-conventional palliative care and untimely death. Non-conventional palliative care occurs during untimely deaths, whether it be through accidents, natural disasters, or global pandemics. Family members that experience this sort of untimely death are predisposed to suffering from complicated grief. In a particular longitudinal study by Gessie, which focused on the 6-year aftermath effects of an earthquake, 11% of individuals were dealing with unremitting levels of complicated grief. Natural disasters are especially traumatic and distressing to individuals. Non-conventional and untimely deaths recently have been highlighted in the news and research due to the COVID-19 pandemic. The inability of a family member to say goodbye to loved ones, constraints of properly mourning afterwards, such as funerals, and communication issues could lead to complicated grief. This pandemic is new, and the negative impact it will have on public health could impact healthcare providers' ability to provide adequate end-of-life care. The last theme developed through the literature review is the lack of nurse preparedness. A survey of 589 undergraduate nursing programs found that 89% of these programs only offered 1 or 2 lectures on palliative and end-of-life care. This lack of education for nurses sets them up for failure to provide proper end-of-life care to their patients. There is an inability to recognize family and patients' needs at end of life, as well as their own need to ensure proper mental, physical, and spiritual health. Heavy workloads, under-resourced working conditions, and highly intensive situations result in the inability for nurses to provide proper end-of-life care. These factors contribute to high levels of burnout and unrest. Due to this, nurses are unable to form a positive relationship between themselves and their patients and family members, thus setting the stage for inadequate end-of-life care. On this next slide, I will be discussing the theoretical framework that shaped my project. The framework chosen was Lewin's change theory of nursing. This theory was developed by Kurt Lewin, who is considered the father of social psychology. There are 3 major concepts within this theory, which include driving forces, restraining forces, and equilibrium. Each of these play a role throughout the change process and may negatively or positively impact the outcomes. Lewin broke the theory down into 3 stages: unfreezing, change, and refreezing. The unfreezing stage involves developing a method that allows individuals to let go of the old way of the driving forces into a new way. For an individual or a group to do so, there must be an increase in the driving forces that directs behavior from the old method to the new method, that decreases the restraining forces that negatively impact the movement from the old method. The change stage involves the process of changing involving the thoughts, behaviors, and feelings about the new method. Lastly, the rephrasing stage is establishing the change as the new status quo. Without fully completing these stages throughout this project, the individuals may regress back to the old status quo. This theory has resulted in significant outcomes in healthcare research. Moving on to an important piece of the project is the overall design. This DMP project is a retrospective chart review that will be completed on one inpatient oncology unit. The methodology used to gather the project's data will be a hard copy categorical survey. This survey consisted of 16 questions formulated in a yes-no format, and one last question opened the survey up to participants to provide a narrative response regarding additional resources utilized throughout the end-of-life process. This survey was based off of Boyle's study that focused on the implementation of an end-of-life protocol. Approval was obtained to utilize this survey through the Oncology Nursing Society. Participants were RNs who cared for end-of-life patients. The sample size was 28 RNs. All nurses caring for end-of-life patients were reviewed for potential inclusion of the survey. The inclusion criteria for this project were the participants had to care for the expired patients, they must complete the entire anticipatory bereavement survey, and the completed survey between December 1st, 2020 through March 31st, 2021. Facility and Maryville University IRB approval was received prior to implementation. After this approval, I provided the necessary surveys and information to the nurse manager, who is designated third-party facilitator throughout this project. The surveys were placed at the nurse's station for staff to complete after caring for the deceased patients. Completed surveys were stored in a locked office until 28 surveys were completed. All surveys remained anonymous and confidential. Once the 28 surveys were completed, I collected all the data and entered it into a data collection spreadsheet. Once this was complete, appropriate statistical analysis could begin. As you can see on this slide, the overall results depicted in this graph are displayed here. Once the data was compiled into the collection sheet, descriptive statistics were utilized to develop a contingencies table representing the results. A contingency table allows for analysis of frequencies between two variables depicted as percentages. This graph was developed based off of this table. The horizontal axis is the questions provided in the survey with a brief explanation of the overall concept posed in each question within the survey. For example, question 2 in its entirety asked the participants whether a call was made to the family to ensure no one dies alone is depicted as call to caregiver on this graph. The vertical axis is the percentages formulated from the contingency table. The blue bar depicts the yes answers and the red bars depict the no answers. As you can see, question 5's blue bar was 100%. This related directly to whether the room was clean, and it was found that 100% of the nurses reported having or finding a clean room. Furthermore, 11 out of the 16 questions reported greater than 80% of participants utilized end-of-life resources, as represented by the blue bars. As you can see by the red bars, end-of-life resources were used hardly at all for memory boxes, pictures, and extra resources. On the next slide, I will group the 5 most used end-of-life resources and the 5 least used end-of-life resources. Here you can see the top 5 utilized activities and the top 5 not utilized activities. Breaking this down, 100% of cases reviewed met their criteria of greater than 18 years of age, and 100% of participants provided a clean room that was free of clutter. 96.4% of participants ensured family preference for privacy during the end-of-life process, family privacy after the patient passing, and lastly assisted the family in gathering the patient's belongings and walking the family members out of the facility. Moving on to the top 5 not utilized anticipatory bereavement protocol. 85.7% of participants did not utilize the memory box that consisted of small mementos and grief resources. 82.1% of participants did not take pictures for the family member after the patient passing. 53.6% of participants did not implement additional bereavement protocol. And 39.3% of participants did not have family members assist the final bathing of their loved ones. And lastly, 28.6% of participants did not talk with the family member about what to expect for their emotional reactions after their loved one passed. Question 16 opened the survey to the participants to provide comments on additional anticipatory bereavement resources and actions. From this information, 3 themes were developed. The first theme being cultural competency. 7 participants incorporated cultural end-of-life practices with the family members and patients. 5 participants participated in smudging and sage burning, while 1 participant participated in last rites. The second theme is staff debriefing. 4 participants participated in staff reflection pre- and post-patient passing. The final theme being grief resources. 5 participants utilized various pamphlets and books found within the oncology department or in the internet. 3 provided family members with the book Gone From My Sight by Barbara Carnes, and 2 participants found community-based grief resources for family members, which provided family members with assistance throughout the beginning grieving process. So, what does all this mean? In summary, the activities and resources most utilized were cultural and spiritual cares, open communication, and family involvement. Activity and resources least utilized were memory keepsakes, final bathing, and pictures. On to what particular limitations and insights were found throughout this project. To refrain from unintended bias, the surveys remained anonymous and the third-party facilitator was put in place so that proper implementation and data collection that refrained from information bias could occur. The sample size was 28 participants. This is a relatively small sample size that does not allow for generalizability to the general population. Due to the limited resources and time, I was unable to gather a larger sample size. With that being said, the results are generalizable to the specific facility. This sample size is adequate in relation to the amount of patient deaths this facility encounters. The last big limitation was the COVID-19 pandemic on this project. Like its impact on everything through 2020 into 2021, COVID-19 played a role in impacting the implementation of this DMP project. The facility this project was being implemented at had a large influx of COVID-19 patients, pulling nurses from various administrative departments to assist with the influx. This caused a delay in obtaining IRB approval from the facility. Furthermore, less of a focus was placed on quality improvement projects, and nurses were less interested in participating in studies due to burnout. On this slide, I will discuss the implications of the findings from this project, which are the following. Through these results, it is apparent that nurse education on end-of-life activities and resources impact quality care. Study after study highlighted how good quality end-of-life care provided a positive experience for nurses, families, and patients. Participants in this survey found that incorporating cultural and spiritual cares into the end-of-life activities helped build a better, more open relationship between staff and families. Next, nurse-patient education on end-of-life activities and resources may help patients enter the bereavement process. The results found show that participants lacked in 3 top evidence-based end-of-life activities. These included memory keepsakes, final bathing, and pictures. More research is needed as to investigate why participants rarely use memory boxes or pictures, determining whether it was due to patient family preference or against cultural practices, or was the nurse just uncomfortable in offering these resources? Lastly, building end-of-life activities and resources requires data analysis, including input from multiple disciplines within and outside of the hospital setting. These multiple disciplines include palliative and hospice providers, chaplains, case managers, family support groups, nurses, and the patient and family members. Open communication and collaboration will build an end-of-life experience that we all can be proud of. In conclusion, nurses with advanced degrees must drive practice using current evidence and prepare for practice changes. Their role in palliative and hospice teams will be essential for them as the increasing number of population continues to rise. Lewin's change theory presents a framework for the steps beyond this quality improvement project. In any change process, ensuring the new process sticks requires motivation, education, and continued focus so that individuals do not return to the old status quo. Nurses and the palliative care team must guide patient caregivers to reduce complicated grief by offering evidence-based resources and activities. As discussed above, complicated grief is a real and complex issue emerging from various factors surrounding a loved one's death. Ensuring appropriate evidence-based activities such as providing grief resources and making memory keepsakes are in place will help refrain caregivers from going down the road of complicated grief. Lastly, and possibly most important, nurses are on the front lines, must build a center of culture and reflective practice to provide safe, quality care and strengthen the nurse-patient bond. Nurses have the unique opportunity to be present at all phases of life. Preparing patients for their final walk through evidence-based anticipatory bereavement activities may ensure the most quality and proficient end-of-life care. I want to thank you all for taking the time to listen to this presentation. I welcome your comments and questions below. Thank you again. And here are my multiple references utilized throughout this DMP project.